This episode is brought to you by the American Academy of Orthokeratology and Myopia Control. Go to aaomc.org and join us. Join the war against the myopia epidemic. All right. Welcome back to the Corrected View podcast. This is a show about Ortho-K. It's a show about myopia control and the people who are devoted to its role in specialty care. And as far as devoted to its role in specialty care goes, you couldn't go much further than hearing the name Dr. Nick Despotidis. He is a practice management guru. He is an expert in orthokeratology, and he's here to help us answer some practice management questions. Dr. D, welcome back to the podcast.
Thank you very much, Matt.
All right. And as per usual, if you have any, we are live. So if you have any questions for Dr. D, go ahead and put them in the chat. And we have some preloaded questions ready to go. So we're just going to start with those. Let me, I will bring them back up on the screen. I had them and then I lost them. So bear with me just a moment. Okay. Dr. D, our first question is, in the very beginning, when you first started doing myopia management, what was your first step? And then today, what would be your recommendations for the first step? So Dr. D, what do you think?
I think initially you have to do two things before you start seeing your patient. You have to make sure you have the right equipment, topographer at minimum, and you have to kind of get familiar with the lens design that you're comfortable with. Those are two very basic things. The third thing is that I would try to galvanize your staff, which is not easy because they're used to us bringing in different specialties like dry eye and maybe medical testing. So you have to explain to them, this is a little different. We have a myopia epidemic. We're coming through this pandemic, hopefully. A lot of kids are nearsighted. And explain to them the reason why you're bringing this in. Just very generalized, but keep those meetings going. If I was to start from scratch, I'd basically allow for one consultation a month. Matt, you've heard me say this over and over again. Now I allow for several consultations a week, but I'd put aside 1 hour a month where I want to fill that with an Ortho-K evaluation at 1 hour at minimum. If it's empty, it's okay. It just means that you need to focus upon it when you're seeing your myopic patients during your general eye exam. You have to have faith. You have to trust me that it will fill up as long as you don't fill it up with nonsense like emergencies or regular exams. There's got to be some pain associated with it. So Step one, make sure you have the necessary equipment and understand at least one lens that you feel somewhat comfortable fitting. You get your staff galvanized. And step three is you set an hour aside a month, because you're just beginning, to do a consultation. And when you're doing a primary care exam and you have a pediatric patient who's myopic, whose parent seems to be interested in doing something about it, you just casually mention, listen, Johnny's prescription has changed. And now there's several options that we have to possibly slow down the progression of his nearsightedness. After all, look, he can't see the eye chart like maybe the 2200E or 2400E. But I need to schedule a separate time where I can devote some time to examine Johnny further, find out what's best for him, and also explain to you what the options are. At that point, you pass the baton to your staff. They'll help Johnny with glasses if you so choose, or soft contacts. And then you train your staff to say, listen, Dr. D recommended a separate visit. He spends an hour with Johnny and yourself trying to figure out what's the best option. They make overnight contact lenses now. They make daytime contact lenses. They even make drops. But these techniques, these therapies require some time to devote to Johnny to see which works best. And that's it. And remember, I think this is the key. 1 out of 40 patients that you recommend will take you up on it. So don't get discouraged when you do it 5 times and you say, Nick told me to set up a consultation appointment and I'm recommending it, and parents are shaking their heads. But once they find out how much it costs or things like that, that's okay. You just need one. You just need one, and you will get that one.
Mhm.
And then the key is, after you get that one, you treat them like we've talked, Matt, for the past 2 years. You wow them into referring friends or family.
Right. So I guess my first question is because I think it's very interesting that you mentioned that be hesitant or be prepared to not fill that space with an emergency. So what happens to that doctor who they're just not filling that space? Like how do you combat that opportunity? Like, how do you keep yourself focused? And like, because I have to imagine that this is a situation where a lot of docs are dabbling and they're just inching into this thing and they put the time aside, it's not paying off, and then there's this immediate pullback, right? So
Right.
how do you keep that space sacred even when if you don't get that patient? What do you do with that space? Is there something useful you can do
You
with
leave
it?
it alone. There's got to be pain involved. We're very conditioned to have insurances fill our books for us. And
Hmm.
that's why we've gotten into this mess, I feel. So,
Okay.
for example, let me give you an example. I I I got involved with Ortho-K over 20 years ago, almost 30 years ago. This year it's going to be 30 years, if you could believe it,
Mm.
1992. In any event, at that time, I didn't know any of this. I was squeezing patients in, and it's almost I was self-sabotaging myself. It was my staff who cornered me. I'll never forget it, on a Monday, who said, "Hey, Dr. D, enough. We got to set aside time." And the reason you're right, Matt, is a practitioner looking at this empty spot says to themselves, I could fill this with 2, 3, maybe 4 patients and
Hmm.
earn a few $100s per patient. And here I am, it's just empty. What that empty signifies is your lack of focus.
Mm.
There's got to be some pain. You just have to have faith that it will fill up. So, one of the examples I always use, about 5, 7 years ago, I'm staying late and I'm busy. I'm so busy with Ortho-K patients, but I'm getting home 9 o'clock, sometimes 9:30. If you know me, I'm an early riser. I like to
Hmm.
go to bed early. And I start scheduling consults for Friday afternoon at 1 o'clock, the most inconvenient time, right? The parents have to take their kids out of school. It's towards the end of the week. Parents have to leave work. And I got to tell you, Matt, it was empty. It was the last choice of a parent. Now, fast forward, it's filled every Friday at 1 o'clock. So, what does that tell me? It was my limiting belief
Hmm.
that parents wouldn't take their kids out of school. So, I just offer your listeners this opportunity to learn from my mistakes, that it will fill up. It just depends on your level of focus. And without pain, you're just going to start filling it up, and then you're just going to just spin your wheels.
Hmm. I like what you said there, and it also reminds me of, because you said 1 in 40. I've heard this from other docs as well, and that seems extremely intimidating. So, is there anything you can do about the remaining 39? Is that just planting the seeds for the future? Do you give up on them? Do you keep going with the messaging? Like,
You go with the messaging. That's right. It's like when I started out doing laser eye surgery and recommending it, and we were even doing it in our office many years ago, is that they would tell us 1 in 7. You recommend it, and 1 in 7 would pick it up. And I don't know if that was true or not. I don't even know if my 1 in 40 is accurate, but I know I have to recommend it to a high number of patients before one translates to a consultation.
mhm.
But you're right. The 39 others, myopia doesn't get better. And I
Mhm.
learned this when I did vision therapy. So the next year, I say, Matt, your son or daughter now couldn't see the 2100 line. They were negative 100, I say. Now they can't see the negative 200. I put up the eye chart and I show the mom. I take my time and say, Johnny is progressing. We're at a crossroads. I've spoken to you about this overnight contact lens called orthokeratology. Yes, you have. It's not covered by insurance, Dr. D. It is not. But there's many things not covered by insurance, but Johnny needs this. Why isn't covered by insurance? I don't know. What I do know is Johnny needs this. Now I can prescribe glasses or increase this power of the contact lenses. That's up to you. But as your family doctor, I'm strongly recommending you bring Johnny back for a consultation. They go out to the receptionist. They said, is it covered by insurance? No, I'm not doing it. Let's just get him glasses. I want my prescription. I'm going to go to Costco. I'm going to get it done somewhere else. That should be pain for practitioners to say, Nick is right. He's onto something. There's a scenario here where they're not following through on my recommendation, but they're also not following through on my recommendation on getting glasses or contacts. And if they are, it takes a lot of energy to keep them there. So we keep stats. We keep stats on how many patients that I recommend, for example, eyeglasses, stay in my practice. And it was, 5%, 10%, 25%. And now we're fighting that. We're combating that by dropping insurances. So the patients who want to see us come to see us and they follow through on our recommendations. So the answer to your question is those 39, every year you keep recommending it. And there'll be one out of the 40 that say, you know what? I don't care. This is getting ridiculous. They can't see the big E now. Let's do something.
Yeah. And I can echo this sentiment. I'm not an optometrist, but I can echo this sentiment in my everyday life. I've been seeing the same therapist for almost 10 years now. From the very beginning, I told her I work with optometrists. They specialize in a specialty. Some call it a lens, but it's more accurate to call it a retainer or a mold that gets put in the eye and worn overnight. It gently reshapes the surface of the cornea using the tear layer, go through the whole thing. She was, when I initially told her about it, she was, this is incredible. How come I've never heard about this? Right. I've brought this up numerous times over the last 10 years. For the first time, my appointment on Monday, she said, you know what? I was talking with a friend of mine and they were mentioning, some issues with the kid and how their eyesight is getting worse. And I thought I should talk to you about that thing that you are involved with, and it's not that she wasn't, it's like after almost 10 years, she was finally like, oh, I can make a connection here. And so I was like, we'll go to here's a link to the AAOMC practitioner search and you can find it. She can find a doctor in her area. So it's like, sometimes you just have to just keep reiterating the point.
That's right. But once you get that one raving fan that we always talk about, Matt, that's why it's critical. That was a really good point, is I focus on not search engine optimization, Google ads, Facebook ads. I don't focus on any external advertising. We've talked about this in previous episodes, because once you get that raving parent, they will go out and educate other parents on this technique for you, because it's exhausting. We just finished saying it's 1 out of 40. That means 40 times I have to explain to parents that their kids are getting worse and there's options for this, and it's not covered by insurance. So those are excellent points, but that should build resolve within the practitioners that want to specialize in myopia management, because it's like anything else. You try to lose weight, you get on that damn scale every day and you're gaining pounds, you're not even losing pounds, and you're starving yourself. But if you stick with it over the long run, something clicks, your body clicks, your mind clicks, you start losing weight, and then you start getting compliments. So it's all is just persistence in anything we do in life.
Yeah, that's a great analogy. I love what you're saying there. All right, are we ready to move to the next question?
Let's go.
Okay, we are getting questions in the chat. I have one already, but we're going to save those for the end. So I will remind the live viewers that if you have questions for Dr. D, get them in now, and then if we have time, we will toss them over his way at the end of, or towards the end of the episode. All right. So for our second question, is it better is it better to charge a global fee or a pay-as-you-go fee? Dr. D, what do you think?
I don't know the answer to that. I just know what I do. I've always charged a global fee because Ortho-K is front-loaded for me. In other words, these consults, the 1 out of 40, we've talked about the insertion removal class. We've talked about virtual meetings beforehand. We talked about getting prizes for the kids. We talked about how this insertion and removal process can take months before the child is doing it on their own and the parents are less anxious. And that's not even the fit. So it takes me a good 6 months to take a parent, from not knowing anything about Ortho-K other than what their friend recommended, to a raving fan. Sometimes it takes me a year. If I charge a fee for a yearly fee, it's most likely this parent may disappear on me. And this happens many times when they go to college. So I have patients I started 20 years ago, longer. So a lot of these kids were 8 years old. Now they're 28. Some of them are 38. So I have trouble with recall. So if I charge them a reoccurring fee, probably I would be doing all this work early on and not reaping the rewards because I've lost them to follow-up. That's the one thing with Ortho-K. Parents somehow are very stressed in the beginning, but their anxiousness gets deflected to something else. Maybe it's SAT, colleges, careers, and then Ortho-K gets on the back burner. And unlike soft contacts, you don't renew that prescription until they lose or break a lens. So what I've done is I front load it. I make sure I calculate my fees as best as possible to compensate me very well for the first 2 years. And after that, we offer parents a maintenance plan, which covers a year's worth of visits. It covers everything except lenses. And it allows me to provide good care, monitor their myopia, monitor their ocular health, monitor their fit at a discounted rate. And most parents, at least over 50%, take me up on that maintenance fee. Later on, when they don't need that kind of TLC, they pay me per visit. So that's my feelings on whether I should charge a consistent fee over the years or a global fee in the beginning.
Excellent. I also that was a great answer. But I also want to point out, kind of like a sideline, that this is the second time I've heard you say, I don't really know the answer to that question, but here's what I think. And I've been hearing a lot from practitioners that they're afraid to not be the expert. They're afraid not to have all of the answers. And that often is an obstacle in their path to getting involved in Ortho-K or myopia management. So I want to take this opportunity to show you, like, Nick's a guru. He's been doing this for a long time. He knows what he's doing. He speaks on practice management and Ortho-K. And even he's willing to sit there and say, hey, I don't know the answer. And that's okay. And here's what I think about that.
Absolutely. And I'm not a guru. Thank you very much. Guru is weird connotation. I could tell you what I am.
Okay.
I've practiced for many, many years. And optometry has afforded me a great life inside the office and outside. And Ortho-K has been a big part of that. And global fees have allowed me to do that. And I also tell parents the same thing. I don't know if I'm the best contact lens fitter for your child, but I can tell you no one will care for your child better than me. And I think we all can do that because parents don't want the cheapest doctor. A lot of practitioners say, I'm afraid to charge X. Well, I got to tell you, you can never win that race. When I charged $1,000, it was no different than $5,000. Price is price. You can never compete on price, but what you can compete on is care, is provide the best care that you're capable of. And parents appreciate that. Trust me when I tell you this, is that they don't want the cheapest doctor. They want the doctor who cares the most for their children. After all, it's their children's eyes. And I'll just close on this statement on this. I'm amazed. I had a parent come in, and this is her third child in our program. And I did the consultation, and she goes, do you give us a family discount? I said, I really don't. There's a number of reasons for that, but I'm going to give your daughter the individual care of giving your other kids. And I never take that for granted. She goes, okay, Dr. D, we're going to go with you. We know you care. And as I'm talking to the mom, I notice she has her frame with a paper clip wrapped around the eye wire, holding it together. Now, I don't know if that's a reflection of her economic state or not, but it's telling me I will hire the best for my child, even when I am not going to get a new frame for myself. Mm-hmm. And that's something that I think Ortho-K should remember. As parents, we really want the best care for our child. You just have to convince yourself you are the one to provide the best care, not the best fitting, the best care.
That's a great point. I love it. And I often hear from patients, or I'm sorry, from practitioners who say that they can't do Ortho-K because their patients are in a low income bracket. And I know doctors, optometrists, Glenda Mohiputh is one of them. I brought her up on the show. You were on an episode of Knowns and Unknowns with her, a webinar that we did.
I remember.
And a lot of her patients are low income demographic, and so speaking to that, it's like, don't take that option away from that parent. They deserve to know what the options are, whether they're going to take you up on them or not. And she says, look, if it's important to them, they will find a way to get the money together for it because it's important to them.
That's exactly right. There's no greater joy as parents is for us to give of ourselves to our kids. And I don't think of any greater gift we could give children is great eyesight, without glasses or contacts during the day, and doing everything we humanly possible can do to slow down their eyes from getting worse.
Well said. All right. Okay, are we ready for the third question? And then
Sure.
After that, we'll take the question from the chat. And I'll remind our live viewers, if you have a question for Nick, you can put it in the chat, or if you have it for a future episode, you can send that to thecorrectedview@gmail.com. If you're an AAOMC full member, you can post something in the Google group, or you can just put it in the Facebook group if you want, and we will answer them at a later time. Okay, so, all right, third question. What do you think of a subscription-based payment plan, and how would you structure it? So, Nick, what do you think?
This is a common theme right now. Even one of my partners has suggested it to me at least once a year. We meet once a month, because that's where people are going these days. It's subscription-based products. And there's certainly reason for that. In my opinion, I think the global fee works best for what we're doing. And I'll tell you why. I just got a notice from Amazon. My Amazon Prime fee is going up from, I don't know. I really don't know. I think it's $140 a month. I don't know what it went up to. But after I got the notice, they went through a list of advantages, of attributes they've added through the years to justify that. And I think without that value-added service, I probably would cancel the subscription. The only subscription that really hasn't given me more value is my cable bill. And I've reduced that through the years. So if you're going to do subscription-based, you have to think long-term. I've been doing this a long time, and I don't do it for the revenue. The revenue is a product of the care I provide. But after I do the fit, after I wow the patient, after I do all these emails, on year 10, what am I doing? So they're going to look at this subscription, whatever it is, and say, what is Dr. D doing? I give workshops. I still hold their hand, but I don't know what added value I would provide to keep this subscription going. So although in the beginning it's very appealing, if I have 100 patients paying, I don't know, $100 a month, this is how much revenue I'm going to get a month. And you may get that for a year or two or three. The question is, you have to be careful, because after a while, you may be spinning your wheels. In other words, you're going to lose people to attrition if you're not constantly innovating. So that's my opinion. Yes, subscription-based sounds very alluring in the beginning, but I'll say it again. We're in the field of medicine, and I truly believe that. I'm going to care for you. I'm going to care for you now. Now is when you need to reimburse me, because your care is really front-loaded. Yeah. I'm not in the business of just lending people money in the long term or bringing out their payment over. I'm in the business of providing the best care I can right now. So for now, for us, this global fee has worked wonderfully well. I'm providing a service. This is how much the service is. This is for how long I provide this service. And this is how much it costs. And it's up to the parent to say, do I want Dr. D, or do I want someone across the street that maybe is charging $100 or $200 a month? I have no idea.
Yeah. Yeah. And I wonder if, it sounds like what you're saying is that like the global fee structure also helps you replace that constant reminder of what you're doing for the patient. Whereas in your case, where you're talking about the subscription, you had to be updated. Oh, by the way, this is what we've been doing for you over the years.
It makes sense, right?
Yeah.
I'm just smiling because I own Truebill. Truebill is an app. I don't know if you're familiar with it. It basically just combs through it, says you're paying the New York
Yes.
Times every month and this.
Mm-hmm.
I don't want eye care, Dr. D, to come up on your Truebill. You're paying
That was
too
going to
much.
be my
You
next
want us
point.
to negotiate with him.
Yeah.
Because what's going to happen? Who's the parent of someone who wants myopia control from their child? It's usually someone that's educated, that is just cost conscious.
Mm-hmm.
They're not gonna do the subscription base for 20 years or 10 years. They may do it
Right.
for a few years and they benefit, not you.
Yeah. That definitely leads into the other point I was going to make, which I personally believe, and this is just my opinion alone, it's based on anecdotal experience, but I think there's going to be a lot of burnout on the subscription model.
Absolutely.
That bubble is going to burst at some point. And to your point, like people have apps or services to help them comb through their subscription services and eliminate them. Like the way I do, like Netflix or Disney Plus or all that, is I look at everything that I want to watch, and then I wait until I'm done watching all of those things. And then I end the service and start another one, and then watch all the stuff that's been building up over time, because that content isn't going anywhere. And it's like, that may work for that model. The subscription base may work for Spotify or Netflix or whatever the case may be. But do you really want that applied to your healthcare system? Do you really want to, get the patient into a line of thinking that's like, well, oh crap, I have this payment for this service. What are we using this for? What's the point of this?
I think this listener is just drinking the Kool-Aid like we all are. The subscription base sounds so good superficially as a business move, but you're right. And remember, my patient base, my tribe, remember the paper clip holding they don't have Disney Plus. They may not even have Netflix. They may have an antenna in their roof. I am telling you, I know my demographic. You can't be everything to everyone. So the subscription base, if anything, in my demographic, may be a red flag. So this is just my opinion. It doesn't mean it's the right opinion, like I said earlier, but I just, the thought of having some app like Truebill contact me to renegotiate my fees is just pretty funny. Funny. I don't want that. I don't want that.
I once considered doing a more subscription-based model for membership, because we have paid members of the AAOMC. Like we have a free base membership if you want to learn all about what we're doing. And then we have a full membership. Dr. D is a full member if you want to support the organization, and there's benefits that go along with that. And at a time when the subscription model started, there was a part of me that was like, should we do more of a subscription model method? And it's like, I'm not opposed to doing monthly payments for membership instead of annual. But at the same time, like, I don't want to fool people into being a member of our organization just because they forgot to cancel it. Like, I want it to be something that you value.
That's interesting. And just a commercial for the AAOMC is that, listen, right now, myopia management is in the limelight, and it's not going to last forever. I do these podcasts without any honorarium because I believe in your organization. What you just said, your ethics, radiate throughout the entire academy. So I encourage everyone listening to support you, because you supported me 20 years ago when your dad was running this, and I was flying to Toronto, just grasping like that first question, that first listener. How do you do this? How do I go about starting? The academy was there for me and literally held my hand. So I'm not a guru. I am someone who follows your members and picks and chooses what I feel is best for me and runs with it. And I encourage the listeners to do the same. Support the academy. Plan on coming to this year's academy. When is it? I think it's in September, Matt.
Yeah, Vision by Design is September 28th through October 2nd, and it's in Bellevue, Washington. I
see all these invitations popping up by these big companies that were nowhere to be found when the academy was first started over 2 decades ago. Why? Because they know practitioners are starved for information. But in my opinion, you go home with the lady who brought you to the dance and who you brought to the dance. And that was the academy. I fully support you, Matt, for
Thank
especially
you.
for what you just said,
Thank you.
is you really want to bring value to us, not really trick us into paying a monthly due that we may forget in the future. And I think those ethics radiate throughout.
Thank you for saying so. And I appreciate the plug for sure.
You're welcome.
All right. All right. So do we have time to take the one question we have from the
Yep,
chat?
sure. Go ahead.
Okay. All right. So here it is. It says, hi, do you have suggestions on scheduling? My myopia parents ask for late nights and weekends. I see general patients in the morning and myopia management after 2. I also know I'm not mentally sharp after 6 p.m. And then they also had, by the way, I do Saturdays once a month and it's difficult to get staffing. Oftentimes I'm there by myself. So Nick, what do you think?
Yeah, I from experience, I feel for this listener. I used to open Saturdays. First 12 years of my practice were open every Saturday. I had 3 partners at the time, 2, and then the third. I would work every third Saturday. I hated it. And when patients came in, they would say to me, listen, I can't make an appointment Saturday. I have Chinese school. I have a soccer tournament. Are you open Sundays? I could never win that game. And the no-show rate was surprisingly high on the weekends. So in 2001, I know the exact date, 2001, we shut off Saturdays. We don't any Saturdays. I learned that from my orthodontist, my kid's orthodontist. They're the best orthodontists in my community. They weren't open Saturdays. I figured, hey, if an orthodontist is not open Saturday, I could do that. And then you just heard me start off by saying I did stay late. I played that late game, and like you, I am not sharp. I'm very sharp in the morning. That's why Matt is taming this in the morning. If we were doing this 8 or 9 p.m., I wouldn't be so enthusiastic. So here's what I recommend is put your consults in the morning. They're very justifiable. The child is rested, you're rested, and you have more time. You can put your checks after 2, but not your consultations. And I suggest schedule them 1 check every 20 minutes at most. If you're just starting out, I would do 1 check every half an hour. Why? Because the checks are the way you market. And I wouldn't stay too late. I think this is a game you can't win. You just can't win. Then as you get more confident, it could take decades or it could take weeks. You start telling patients, listen, I don't have evening appointments for you, but when you come in, I will spend 20 minutes just with you. There's no rushing. I don't want my waiting room crowded again. Even though COVID may be getting better, I don't want to go back to my waiting room being this crowded place. I will speak to you face to face. And we've talked about some of the things, and maybe in future podcasts, how I've developed my practice to accommodate the endemic that we may be entering. So this listener, I encourage them to move their consults to the morning, their most difficult cases to the morning. I also learned this from a dentist, good friend of mine. All his difficult surgeries, his cases were in the morning, and put your checks in the afternoon. You will still go home drained, but just do it enough to develop enough confidence to start saying, listen, my last appointment, I can't tell you, I think our last appointment right now is at 5:40 maybe, and we won't get out sometimes at 6:30, and just vote for the quality of your life more than anything else. If you're worthy of their patronage, they will come when you're open. Just think of yourself. Are you going to go to the cheapest doctor? The doctor who's open Sunday, like these 24-hour medicine places? Or are you going to go to the doctor who's going to listen to you, who knows you, and takes good care of you? You can't be everything to everyone. You can't be everything to everyone.
Yeah, and there's a strong perceived value. We talk about this a lot, about perceived value, and I think this speaks to you talking in the past about dropping your fees or offering discounts. But if your checks, it seems like to me, and correct me if I'm wrong here, but it seems like to me, if you're putting these appointments in the morning, you're sending a message to that patient that this is very important.
Yes.
You know, I'm not surprised to hear you say that doing this on the weekend, then you get no shows, because the weekend's for relaxation.
or also for recreation. I mean, these are
Mhm.
when the kids have sports and music lessons and SATs and SAT tutoring. So you can't win that race. You just can't win that race.
Well said. Well said. All right. Well, that is our last question, and we're coming up on time anyway. So, Dr. D, thank you very much for your time.
You're
Looking
very
forward to
welcome, Matt.
Supercharge, which is coming back at Vision by Design. If anybody has any information about Supercharge or wants to know information about Supercharge, sorry, where should they go, Dr. D?
Uh, they could just forward it to you, Matt.
Okay.
This year, I'm changing it around. I've changed it 100% just to accommodate practitioners who really want to dedicate themselves. I'm going to restrict the attendance because I just think even in September, we won't be back to normal. And number two, I'm
Right.
going to make it a full day course where I'm going
Oh,
to
that's awesome.
really uh, delve into the specifics. So when they do go back, they'll have all the details that I've really refined, unfortunately, over the past 3 years. I think it'll be 3 years since I've had the last Supercharge. So a lot has evolved in our practice.
That's awesome. Yeah. And if for anyone who's taken it before, I've heard of people taking it multiple times because you do change it and update it, and the energy is infectious. Like I remember, at a past Vision by Design, I'm like rushing something down the hallway, like a cart of projectors or something, and I look over, and there's this just awesome line of super energized people who are clapping and dancing and moving with Dr. D's at the head of the line, like. He just really knows how to bring up the energy and creates this awesome experience that any person who I have asked to have attended it, they've said it's incredible and life changing. So,
Thank you, Matt.
yeah, no problem. The proof is in the pudding. So
Yeah, thank you.
it's very easy to compliment it.
I look forward to doing it this year in Washington State. So it's going to be awesome.
Definitely going to be awesome. And if anybody's looking for more information or want to get in contact with us, thecorrectedview@gmail.com. And if you're interested in becoming an actual full member of the Academy, aaomc.org, or even if you just want to come in and see what we're all about, there's a free base membership. All right, Dr. D, thank you very much for your time.
Thank you, Matt.
All right, and
See you
we'll
next
see you
month,
the next
okay?
one. Definitely.
All right, take care.
Well, that's it for this episode of The Corrected View. And if you enjoyed this podcast, be sure to thank the standard members of the American Academy of Orthokeratology and Myopia Control, whose annual dues and support make it possible for the AAOMC to put out education, awareness, and content like this. And I'd also like to give a special shout out that I'm going to be giving out at the end of every Corrected View episode for 1 full year. And that shout out goes to Dr. Somi O for her very generous contribution at the lifetime member level of our fundraiser. Thank you to everyone who contributed and keeping the AAOMC alive. You are awesome.